Philippine Pediatric Society Northern Luzon chapter for inviting us to talk on a topic that is close to our hearts. But since I will be sharing our patient, may I just request all of you, please, not to take any picture of the patient involved and no recording of the video that I will be presenting. So I have nothing to disclose. So tuberculous meningitis is a medical emergency, and any delay in diagnosing and adequately treating this condition is associated with significant morbidity and mortality. So I hope with this webinar, which is my objective, is to review with you and assist you in early identification, proper investigation, and timely treatment of tuberculous meningitis in children in order for us to reduce the neurological morbidity and mortality associated with it. So please answer my poll question. If you have a patient, a 9-year-old patient at the emergency room with 3 weeks history, what among these symptoms would make you suspect that your patient is suffering from tuberculous meningitis? So please answer. There are more than 400 attendees, so if you are, please check your best choice. 5, 4, 3, 2, 1. So let me see. Oh, very good. 83% answered all of the above. So you are correct. We all know, next slide please. So we all know that tuberculosis per se has protean manifestation, and more so with tuberculous meningitis. So depending on the phase of illness of this particular patient, you expect different symptomatology. So the first phase is composed of non-specific signs and symptoms. So your patient could have just malaise, headache, low-grade fever, or changes in their moods. And on the first phase of your illness, also called the early prodromal phase, which lasts about 1 to 2 weeks, this makes it difficult for us to suspect and diagnose TB meningitis in the first phase. All of this symptomatology can be seen in any form of meningitis, as in the case for our patient who was initially managed as dengue, then CNS infection bacterial. Okay? So in most cases, a history of contact with an active patient of TB children, about 50%, can also be elicited, but about 10% of TB meningitis has no prior history of pulmonary symptoms. How about patients on the meningitic phase or phase 2? Most of these patients already would manifest with frank neurologic symptoms such as decreasing sensorium, confusion, presence of a cranial nerve palsy, presence of vomiting. Altered consciousness in 59%. They could have palsies in 1/3 of cases. And second phase is usually very abrupt in onset, lasting again for 1 to 2 weeks. How about the paralytic phase? The paralytic phase is the first third phase in which these patients already might have decorticate or cerebrate posturing. You could have plegia, multiple nerve palsy, or patients going into coma and maybe succumb to death. And this again lasts around 1 to 2 weeks. So since tuberculous meningitis presents subacutely, an average of 10 days for each phase, and 57% lasts about 1 to 3 weeks, and more than 3 weeks in 36% of cases, as with our very own patient. And with all these phases, this corresponds to a stage of severity which we call the Medical Research Council grading of severity for tuberculous meningitis, for early prodromal phase, grade 1, if your patient is still awake and there's no focal deficit. But for grade 2, these are patients that has a Glasgow Coma Scale of 11 to 14 with mild focal deficit. And for grade 3, these are already patients below Glasgow Coma Scale 10 and with moderate to severe neurologic deficit. All of these features of symptoms is a result of the basilar meningeal fibrosis and vascular inflammation. But caution, there are patients presenting with tuberculous meningitis that were in fever and frank nuchal rigidity can be absent. So correlating all of this symptomatology and phases with our very own patient who had a 3-month history presenting initially with non-specific signs and symptoms and eventually decreased sensorium and regression of motor skills, and on neurologic exam with a Glasgow Coma Scale of 11 with a focal neurologic deficit and presence of nuchal rigidity, our patient can be classified under meningitic phase and level of severity is grade 2. Now, how about our diagnostic tests in diagnosing tuberculous meningitis? What do you think is the best choice or choices in diagnosing TB meningitis? Please answer the poll. 5, 4, 3, 2, 1. Submit your answers. So, Bapol. So it's all of the above. Very good. Thank you very much for answering the poll. Next slide, please. So confirming the clinical suspicion of tuberculous meningitis has always been problematic from time immemorial. So only about 45% of patients will have chest radiographic evidence of past or present tuberculosis, and only about half will have a positive tuberculin test. A number of strategies have been attempted to improve the laboratory diagnosis of tuberculous meningitis. So for all patients wherein you are entertaining a CNS infection, whether viral, bacterial, or tuberculosis, performing a lumbar puncture is a must in evaluating these patients. So for routine CSF analysis, what is expected of tuberculous meningitis is an elevated WBC count with a differential count predominantly lymphocytes. The protein will be elevated. There will be a decreased CSF glucose serum ratio. And at times, if you're able to request for CSF lactate, then it will be elevated. But doing the routine CSF analysis would only yield at about 10 to 15% sensitivity. Okay, next slide, please. So what are the other uses of our CSF? So for the past 20 years as a fellow in neurology and up to the present time, a lot of tests have been mentioned to help us in diagnosing tuberculous meningitis. So the conventional, as we all know since med school, is the acid-fast staining using Ziehl-Neelsen stain for smear examination, which gives us approximately 50% sensitivity with suspected tuberculous meningitis. However, the problem with doing the acid-fast smear stain is that the yield is very low because, one, you need a lot of specimen, about 10 to 15 ml. And second, you have to do the lumbar puncture immediately before or at least after starting treatment, immediately after starting treatment. And there's a special centrifuge force that you need to do, allowing it to be centrifuged for 20 minutes and another 20 minutes to identify the acid-fast bacilli. So in actuality, in our setup, in Biogen, we rarely request anymore for the Ziehl-Neelsen acid-fast smear. The laboratory doesn't perform it anymore. And from 2007 up to 2019, when I reviewed all the journals, next please. Using the gold standard or conventional Lowenstein-Jensen media, which gives about 60 to 70% sensitivity to culture Mycobacterium tuberculosis, it will take about 4 to 6 weeks to obtain a positive result. Newer methods in culture have been devised, making it to have a positive result to 1 to 3 weeks. But still, it takes a long time to get a positive result, if ever you will get one. That's why this conventional or gold standard method is also no longer being used in our institution. Next slide. So despite all these conventional or gold standard ways of diagnosing TB meningitis, a very promising and new method is replacing the older methods. And this is what you call the polymerase chain reaction assay or the gene expert. And this is having popularity and replacing the other traditional methods because of the rapidity of result. About 48 hours, you can get the result, and giving a sensitivity of 75% and specificity of 94 to 100%. Okay. This is offered in our institution, and as Dr. Gwyneth Leeson said, it's already offered in most regional hospital, and this is for free once you send your patients for screening in the TB Dots Center. Next slide. How about neuroimaging? Is there a role? But if ever you're going to request, which is more important, doing the cranial CT scan or doing the cranial MRI? So it is very, we all know that the cranial MRI has a higher sensitivity than cranial CT scan. It is very reliable in defining lesions in deeper areas of the brain, such as the brainstem, midbrain, and basal ganglia. Doing a cranial CT scan is for emergency evaluation if there are signs of increased intracranial pressure, or if you are evaluating for the presence of hydrocephalus or presence of hemiplegia. However, another caution is that this itself may be normal in approximately 30% of cases. Thus, a normal neuroimaging initially does not rule out the possibility of tuberculous meningitis. Next slide. So another question, my favorite. Whenever we make rounds with my residents, I always ask them the Triad Findings. So among the choices, what do you think comprises the Triad Findings in tuberculous meningitis that will help you in diagnosing these patients? So the poll starts now. 5, 4, 3, 2, 1. Okay, what's your answer? So it's A, B, and D. Nako, ang gagaling naman ninyo pong lahat. So that's the correct answer. Thank you for answering. Next slide. So the usual findings in doing neuroimaging in tuberculous meningitis, as you can see, in 80% of cases is the presence of communicating hydrocephalus, followed by basal meningeal enhancement, third, presence of infarcts, and lastly, tuberculomas. So if you see in your imaging the presence of hydrocephalus with basilar meningeal enhancement, then correlating with your history and neurologic exam, then this is strongly suggestive that your patient might have tuberculous meningitis. Next slide, please. So this is the actual cranial CT scan of our patient that was presented. So the first CT scan will tell you that this is a plain cranial CT scan. There is a dilatation of all of your ventricles with cerebral edema, and there's already subependymal effusion, meaning the CSF is already seeping out of your ventricles. The middle image is the contrast, And this will show you that aside from the dilatation of your ventricles, you already have the enhancement in the middle. So that's what you call the basilar enhancement. And the last image on the right, on my right, is the follow-up CT scan of our patient showing progression of the hydrocephalus after 4 weeks. So this is the triad. So other images that I'm showing you right now are the other findings in tuberculous meningitis. So the circular one is the tuberculoma. And on the one with the arrow is an example of the infarct that you can see together with the dilated ventricles. On the right side, on my right, is a more enhanced image showing meningeal and basilar enhancement, which looks like a star, if you can imagine a star, encircling the third ventricle. Okay. Next slide. Now, correlating your clinical history, your CSF result, and your neuroimaging, all of these three are used together in order to strengthen your impression of tuberculous meningitis. So how are we going to use all of these parameters? Next slide. So here we have a table that I'd like to walk you through since it's a very busy. So for every symptomatology corresponds a specific score. Okay, so it could be a clinical criteria, the CSF fluid criteria, the imaging criteria, and evidence of tuberculosis elsewhere criteria. So correlating with our patient, again, our patient on clinical criteria scored 6 because the symptom lasted for more than 3 months, and patient had already a medial rectus palsy with decreased sensorium of GCS11. Followed by a positive CSF fluid, which is 3, with a 55 WBC count, elevated protein, and a decreased CSF glucose ratio. And on our imaging, a 3 score, since our patient already had mild basal meningeal enhancement and presence of hydrocephalus. Okay? With all of these criteria, you are now able to use all of these armamentarium, whether to classify your patient as having definitive TB, probable TB, and a possible tuberculous meningitis. So you have a total score of 12. So with this score, plus exclusion of other alternative diagnoses, and 2 points for each CSF and imaging, then our patient can be categorized as having probable tuberculous meningitis with British Medical Research Council level of severity stage 2. Next slide. So if you already diagnose your patient as having tuberculous meningitis, how long and what treatment should we give? Okay. Our patient was given quadruple therapy with corticosteroids, and WHO recommendation is we should treat for 9 to 12 months. But because of a lot of anticipated relapse or resistance, I personally treat my patients 12 months. Next slide. So aside from medical management, since we all know that hydrocephalus is the most common complication of tuberculous meningitis, then we might need to refer our patients to our friends in the neurosurgery department. But mind you, not all hydrocephalus can be treated surgically. Okay, 80% can be resolved with medical management alone. And if we can manage them medically, all the better, because patients with tuberculous meningitis having hydrocephalus as complication have higher morbidity when they have a shunt because of other conditions. So malnutrition, so you have easier blockage of your shunt because of the high protein level. Okay, next slide. So I am very happy to tell you that during my neurology fellowship, one of my research, and I was able to present it in the World Congress of Neurology in Bangkok in 2008, was a study evaluating the clinical outcome of Filipino children with tuberculous meningitis, hydrocephalus in a tertiary hospital. So a total of 63 patients, but I was only able to review 49 for completeness of chart from January 2003 up to December 2005. And we evaluated patients with tuberculous meningitis, hydrocephalus if medical and surgical management would make a difference. So for those patients who are medically managed, we treated them with acetazolamide coupled with either acetazolamide alone or a combination of acetazolamide with serial lumbar puncture. And as you can see here in our table, patients from stage 1 to stage 3 were either reviewed for conservative treatment alone or a combination. And for most patients on conservative treatment alone, 78% had resolution. They didn't undergo surgery. But for some patients who had progression, we tried to combine conservative acetazolamide with lumbar puncture and had 87.5% success. As you can see, most of our patients belong to stage 2 level of severity. Next slide. So how about those patients who underwent VP shunting? So for these patients, they're again mostly on stage 2 level of severity. Those who had outright VP shunting, there was improvement in 93% of cases. But there are some patients who belong to the severe stage, which is stage 3. Our protocol is first to insert a tube ventriculostomy and observe for improvement within 72 hours. If there's improvement, then we proceed to definitive VP shunting with 66% improvement and had 1 mortality. Okay, so if there is hydrocephalus and there is progression, a shunt should be properly offered in case there is failure of medical management, or if there is a severe non-communicating hydrocephalus, or there is neurologic deterioration, so that we will not lead to irreversible brain damage. Okay, so aside from VP shunting, a new method is the called endoscopic third ventriculostomy. So in this type of surgical intervention, we don't need to put any foreign body, which is the shunt. All we need to do is do an invasive endoscopic, so it's like an endoscopy. We insert a tube to broaden the third ventricle. Okay, so I'm just happy to say that with the research that I presented, one of my students got encouraged and pursued neurosurgery during his fellowship and pursued further endoscopic third ventriculostomy in Africa because of this research as an inspiration for his career. Next slide. So this is the actual CT scan of our patient. As I mentioned earlier, there was progression 4 weeks after trying to do medical management with serial lumbar tap. Next slide. So this patient eventually had a shunt inserted in her head. Okay. Next slide. So even if we did try our best to treat our patients and give initiated early treatment, we still anticipate complications. So the complications during treatment and after treatment can be summarized as either immediate, and that is addressing signs of increased intracranial pressure or the problem of hyponatremia and having the SIADH syndrome or syndrome of inappropriate antidiuretic hormone, or if there is vasculitis leading to stroke. You could have short-term or long-term sequelae. Short-term, presence of hydrocephalus or the cranial nerve palsy, or again, progressing raised intracranial pressure. And the most devastating is the presence of the long-term sequelae. So you could have the cognitive disability, mood swings, emotional lability, or the presence of physical limitation if there's no recovery from the stroke event. And patients can develop epilepsy for these patients. Okay? Some can go blind and some can be deaf or have deafness. So for my particular patient, this patient suffered blurred vision despite completing the treatment. Next slide. So how about prognosticating markers for our TB patients? So a lot of journals have mentioned neurologic status at the time of presentation and the time to treatment initiation. So as much as possible, let us not delay initiating treatment of beyond 3 days. And some researchers have found that the presence of hydrocephalus and marked basilar enhancement corresponds to a poor prognosis. And the lastly is the clinical stage at admission, wherein whatever category they were placed in the British Medical Research Council level of severity, they found out that the advanced stages of disease had poorer outcomes. Next slide. And just to give you an objective finding, is a journal published from January 2009 and July 2015. They tried to evaluate the imaging of these patients and correlated with the outcome. And noteworthy here is what is significant, statistically significant for them, is the presence of infarction. So I've mentioned earlier that basilar enhancement and hydrocephalus corresponds with a poor prognosis, but for this journal, which is latest, it is more of the presence of the bilateral basal ganglia infarct. Next slide. How about in the study that I presented in Bangkok? So from whether it's 2000, 2003, 2017, or 2020, most of the journals that I have reviewed still has a conclusion that the severity grade at admission is the single prognosticating factor of what would happen to our patient. So as you can see, for our patients who were under stage 3, 84.6% had a poor outcome as compared to all patients who were on stage 2. Next slide. So for our last 2 slides, so for our mortality, 50% adults can succumb to death and only 20% in children, especially so higher mortality if these patients have advanced disease on presentation and concomitant HIV. So there's still no exact reason, okay? But they found out that children have more neurological deficits as compared to adults. However, adults have higher mortality rate. So just to share our patients. So this is our patient during admission. And 60 days after, the patient underwent VPS insertion. And 6 months post-op, this is already our patient. From being vegetative or debilitated, on NGT feeding, as you can see, she's already awake, conversant, and ambulatory. That was June of 2018. And 2019, this is now our patient who fully recovered motor skills, but sadly, she has a problem with her vision. Okay, so I hope you got inspired with our patient. Okay, next slide. So to end, despite the advances in medicine, tuberculosis meningitis still kills or disables around half of our sufferers, especially children. Although some progress has been made, there remains a need for us to develop sensitive diagnostic tests, better drug therapy, improve management of these complications, and understanding of the host-directed therapy if our outcomes are to improve. Thank you very much.